So today I am going to teach you a very important topic that is termed as Myasthenia Gravis, which is represented by MG. That is Myasthenia Gravis, and Myasthenia Gravis, it is also termed as gold flame disease. It is also known as gold flame disease. So what is the second name of the Myasthenia Gravis? That is gold flame disease. Now Myasthenia Gravis, actually it is a combination of two words. By myasthenia it means that is muscles. Myasthenia is related with muscles, while gravis is related with severity. So what does it mean? It means it is the severe disorder of the muscle. It is severe disorder of muscle. Now, in nervous system, there are two diseases in which neurotransmitter deficiency are there. So, what are those diseases? There are two diseases in nervous system in which the neurotransmitter deficiency are there. The first is Myasthenia Gravis. That is Myasthenia Gravis, while the second is Parkinsonism, which is also called as Parkinson disease. Parkinsonism. Now, in Myasthenia Gravis, there is deficiency of which neurotransmitter? That is acetylcholine. So, in Myasthenia Gravis, there is deficiency of acetylcholine. While in case of Parkinsonism, there is deficiency of dopamine. Now in this lecture we will be more focusing with Myasthenia Gravis. As in Myasthenia Gravis, it is the acetylcholine deficiency disease. So before discussing Myasthenia Gravis, it's important that we should know about the acetylcholine. That what is actually acetylcholine? So acetylcholine, it is the excitatory neurotransmitter. Acetylcholine is excitatory neurotransmitter. It means that whenever acetylcholine bind to acetylcholine receptor, it will help in the muscle contraction. We will be discussing it later in detail, but just keep in mind that acetylcholine is excitatory neurotransmitter. Secondly, it is also known as learning neurotransmitter. The second name of acetylcholine is learning neurotransmitter. Every neurotransmitter has another name. So for the acetylcholine, the another name is learning neurotransmitter. Now acetylcholine play a very important role in the central nervous system and peripheral nervous system. So it play an important role in central nervous system and peripheral nervous system. As you know that central nervous system consists of brain and spinal cord, while the peripheral nervous system, it consists of nerves. And what is the function of peripheral nervous system? It gives information to the CNS, and from the CNS the information reach to the body organs by peripheral nervous system. So the point is that the acetylcholine has a very important role in case of central nervous system and peripheral nervous system. So how actually it play a role in the CNS and PNS? So if we talk about in CNS, so these are considered as the cholinergic projections. These are cholinergic projections from forebrain to cerebral cortex and hippocampus control the cognitive functions in targeting area. So in case of CNS, actually the role of acetylcholine are as these are the cholinergic projections from forebrain to the cerebral cortex, where the hippocampus control the cognitive function. But if we see in peripheral nervous system, it helps in the activation of muscle. It helps in activation of voluntary muscles. Also, it is considered as a major neurotransmitter in autonomic nervous system. So in peripheral nervous system, what is the role of the acetylcholine? These are helps in the activation of voluntary muscles. Also, it is considered as a major neurotransmitter in autonomic nervous system. So it is important. Now, actually, the myasthenia gravis, it is a motor disorder. The myasthenia gravis, it is a motor disorder. It is a motor disorder in which weakness occur in voluntary skeletal muscles. So, what is myasthenia gravis? Actually, it is a motor disorder. Motor disorder means that the information can reach to the brain, but our brain cannot able to respond to that information. That is motor disorder. So, it is a motor disorder in which weakness occur in the voluntary skeletal muscles. As you know that the skeletal muscles are voluntary muscles, while the cardiac muscles are involuntary muscle. So it helps, actually it is a disorder, it is a motor disorder in which weakness occur in voluntary muscles. So it's important, but let's define the myasthenia gravis in a more proper way. How we can properly define the myasthenia gravis? So actually it is the chronic neuromuscular disorder. It is a chronic neuromuscular or autoimmune disorder, or also it is irreversible disorder. It is chronic neuromuscular or autoimmune irreversible disorder characterized by weakness and abnormal fatigue of voluntary skeletal muscles. So this is the proper definition of myasthenia gravis. How you will define the myasthenia gravis? Actually, it is a chronic disorder. Chronic means that the diseases actually occur in a more slow pattern. The pattern is slow and it has not a sudden onset. Secondly, it is a neuromuscular disorder, meaning that it is a disorder of the neuron in the muscles, and also it is an autoimmune in which our own immune system, it acts our own body says, while it is irreversible, meaning the disease is not reversible. Once it happens, once it occurs in an individual, it can proceed further and the condition is more deteriorating. So also there is a weakness in a condition and abnormal fatigue of voluntary skeletal muscles. Now, actually, what are the most commonly affecting muscles? So the most commonly affecting muscles are of eye, face, and swallowing. So what are the most commonly affecting muscles? The most commonly affecting muscles are of eye, face, and swallowing. Now let's discuss the causes of the myasthenia gravis. What are the causes of myasthenia gravis? Before moving toward the causes of myasthenia gravis, it's important that we should know about the neuronal structure. What is the structure of the neuron? So, as we are familiar about it, these are the dendrite of the nerves, these are axons, and these are axon terminals. So there is another neuron having dendrite, axon and terminal axon, and inside there is cell bodies. Now these are dendrites, these are cell bodies, these are axons are and axon terminals. Now the point is that actually the impulses are carried by dendrite. The impulses are carried by dendrite, and from the dendrite the impulses reach to the cell bodies. The impulses from impulses from dendrite, it reach to the cell body as we are very familiar about it, and from the cell body the impulses are transmitted to the axons, and from the axon it is transmitted to the axonal terminals. From the axonal terminals the impulses are carried by dendrites of another neurons, and after that that impulses transmitted to the cell bodies and ultimately to the axon and to the axonal terminals, and this the impulses is moving from the one neuron to another neuron. So this is how actually the impulse is transmitted from one nerve to the another nerve. Now let's say we have two nerves. Let's suppose we have two nerves. Now this is called as, let's suppose this is the presynaptic neuron. It is called as presynaptic neuron. It is a postsynaptic neuron. So just imagine if this is a neuron and this is the muscles. So the junction between the neuron and the muscles, that is called as neuromuscular junction. So it is neuromuscular junction, meaning the junction between the neuron and the muscles. Also it is termed as synapses. It is also called as synapse. So this is the presynaptic neuron, this is the postsynaptic neuron, and this is the neuromuscular junction, or it is also called as synapse. Now, on the surface of the postsynaptic neuron, there are receptors are present. On the surface of the postsynaptic neurons, there are receptors are present. And what are those receptors? These receptors are called as acetylcholine nicotinic receptor. It is called as acetylcholine nicotinic receptor, and it is present on the surface of the postsynaptic neuron. Also there are another site in the postsynaptic neuron, and these are present in another site, and these are called as cholinesterases. These are termed as cholinesterases. Now the acetylcholine receptor, these are the receptor site of the acetylcholine, while the cholinesterase, these are the inhibitory side of acetylcholine, meaning it will inhibit the acetylcholine. Now in the presynaptic neuron there are a lot of synaptic knobs are present. There are synaptic knobs are distributed throughout the presynaptic neuron. Inside of the synaptic knob there are synaptic vesicles are there. Synaptic vesicles are there, and vesicles contain the neurotransmitters. Vesicles contain the neurotransmitters in the form of acetylcholine. Once the impulse comes there, or impulse when action potential comes there, so what happens that these acetylcholine, it will jump from the presynaptic neuron to the neuromuscular junction or synapses. Once the acetylcholine it binds to the acetylcholine nicotinic receptor, so what happens? When it binds to the acetylcholine nicotinic receptor, so as we discussed earlier, the acetylcholine is an excitatory neurotransmitter, meaning whenever acetylcholine binds to the acetylcholine receptor, it will activate the muscles, and thus there will be muscles contraction there. Now after that there will be muscles contraction occur. Now let's say these acetylcholine that reach to the postsynaptic neuron, so it will help in the muscle contraction, but there are certain acetylcholine which is extra, which are of no need. So for that there are cholinesterases. The cholinesterases are the inhibitory site of the acetylcholine. So the extra acetylcholine it will take by cholinesterases. The extra acetylcholine, it is very important that the extra acetylcholine it will take by cholinesterases and it will inhibit the acetylcholine further. And why it is so? In order to produce the adequate muscle contraction, because we need the adequate muscle contraction. So the extra acetylcholine must be inhibited by the cholinesterases. So because the hyperkinetic or hypokinetic, both are of the problem. The hyperactivity of the muscles and hypoactivity of the muscles, it is also, both are very, we should not want that. So for adequate muscles contraction, we need the adequate number of acetylcholine. So the adequate number of acetylcholine, it will help in the muscle contraction, while the extra acetylcholine, it will be taken by the cholinesterases. So this is the normal mechanism of nerve impulses and how actually the muscle contraction occur. Now actually what happens in myasthenia gravis? Let's discuss the actually in myasthenia gravis what are the circumstances are there. So in case of myasthenia gravis, the antibodies are produced, and that antibodies that are actually act on the acetylcholine receptor. I repeat, what happens in myasthenia gravis? In myasthenia gravis, the antibodies are actually attached and antibodies are bind to these acetylcholine nicotinic receptor. So antibodies will bind to the acetylcholine receptor. So when antibodies bind to these acetylcholine receptor, so there is no more binding site for acetylcholine. So the acetylcholine is unable to bind the acetylcholine receptor, so meaning the acetylcholine level decreases. So when there is decreased level of acetylcholine, so there will be no any muscle contraction or there will be inadequate muscle contraction. So I repeat, what is the most common cause of the myasthenia gravis? And myasthenia gravis, the antibodies bind to acetylcholine receptor. When antibodies combine to the acetylcholine receptor, so the acetylcholine is unable to bind to the acetylcholine receptor. So what happens? The acetylcholine level is decreases. So if there is decreased acetylcholine level, so it will lead to the inadequate muscle contraction. So it is the most common cause of the myasthenia gravis. So what is actually the other cause of myasthenia gravis? The other cause of myasthenia gravis is when there is increased level of cholinesterases. When there is increased level of cholinesterases, and as I told you earlier, the cholinesterases are the inhibitory site for the acetylcholine, meaning it will inhibit the acetylcholine. If there is more level of cholinesterases are present, it will inhibit larger and more number of acetylcholine. So the acetylcholine level ultimately it will be decreases. So again there is inadequate muscle contraction will be there. Thirdly, if there is calcium deficiency, the calcium deficiency also lead to myasthenia gravis. And why it is so? Because calcium helps in the impulse transmission. So if there is calcium deficiency, so the impulse is not transmitted properly. So it is also very important. Now, thirdly, if there is defect occur in the postsynaptic receptor. So what happens if there is defect occur in the postsynaptic receptor? So if the defect occur in postsynaptic receptor, so the acetylcholine will be not in a position to bind the acetylcholine receptors. So ultimately there will be decreased number of acetylcholine, which lead to inadequate muscle contraction. And at last, there is another condition which can lead to the myasthenia gravis. And what is those condition? That is called as thymoma. That is thymoma. Thymoma is actually, it is the cancer of thymus gland. So what is the another cause of myasthenia gravis? That is thymoma. Thymoma is the cancer of thymus gland, and actually thymus gland, it produces the thymosin. It produces the thymosin. Now, how the thymosin actually causes the myasthenia gravis? Now, there is two roles of thymosin. There is two roles of thymosin. First, the thymosin, it helps in T cell activation. It helps in T cell activation. After that, the T cell, it will signal the, it gives signals to the B cells for activation. Now when it gives signals to B cells for activation, so upon the activation of B cell, the B cell will produce antibodies. These B cell, it will produce the antibodies. And those antibodies that will bind to acetylcholine receptor. So if these antibodies bind to acetylcholine receptors, so ultimately the acetylcholine level will be decreases because the binding site of acetylcholine is no more there. Now this is the first way how actually thymosin, it causes the myasthenia gravis. Thymosin, it will produce, it will activate the T cells. T cell gives signal to B cell for activation, and B cell function is production of antibodies. Those antibodies, it act on the postsynaptic receptor. So upon acting on activation, when the antibodies act on the acetylcholine receptor, so acetylcholine will not bind to the acetylcholine receptors because of unavailability of that receptor. Secondly, the thymosin, it produces specific proteins, and that is called as thymopoietin. That is called as thymopoietin. And the major function of thymopoietin is that is acetylcholine receptor destruction. Actually, it destructs the acetylcholine receptor. So ultimately, there will be decreased acetylcholine level. So this is how the thymosin actually it causes the myasthenia gravis. So now let's coming toward the clinical presentation of a patient if one is suffering from the myasthenia gravis. Now, what are the clinical features? As I told you earlier, that it is a motor disease, and which weakness occur in voluntary skeletal muscles, and the most commonly affecting muscles are muscles of eye, face, and swallowing. These muscles are usually affected. Now, how actually patient will be presented? So initially, the most early and classical sign of myasthenia gravis, that is ptosis. So the first is there is ptosis. Ptosis means drooping of eyelids. Drooping of eyelids. And how much drooping of eyelids actually are there? That is from 2 millimeter to 6 millimeter. Actually, the ptosis, it is also termed as curtain sign. It is also as curtain sign, and it is the first clinical presentation of a patient if one is suffering from myasthenia gravis. Now let's suppose this is a eye, this is a eyeball, this is a eyelid. Now in the eyelids there are two sort of muscles are there. The first is levator palpebrae superioris and the orbicularis oculi. The orbicularis oculi is the first muscle that's stiff after the death. It is very important. Always keep in mind that the orbicularis oculi is the first muscle that's stiff after death. Now, the levator palpebrae superioris, actually it do not show respond. It will not respond though the information reached to the levator palpebrae superioris, but it will not show any respond to that because of lack of acetylcholine. Because of lack of acetylcholine, so it will lead to the condition of ptosis. Also, there will be important features, that is diplopia. Diplopia means here the patient has a double vision. Also, the most commonly affecting muscles are face as well. So there is hanging jaw sign. So hanging jaw sign is very important. Hanging jaw sign meaning that the jaw is hanging. So, and why it is so? Because of affecting of the muscles of face. So due to affecting of facial muscles. Due to affecting of facial muscles. And also there is dysphagia. Also means difficulty in swallowing. Is it mainly involves the muscles of swallowing as well. So when it affects the swallowing muscles, so there might be dysphagia. If the laryngeal muscles are involved, so also there will be harshness of voice because of laryngeal muscles involvement. Also, depending upon the muscles involvement, it also leading to the breathing difficulty. And there might be respiratory paralysis as well. So these are certain important clinical presentation of a patient with a myasthenia gravis. So the ptosis, what is the most important signs in symptoms of a patient? The first is ptosis, which is also called as cutting sign, diplopia, hanging jaw sign, and dysphagia. So always keep in mind that the muscles of eye, face, and swallowing, it is usually affected in case of myasthenia gravis. Now let's discuss the diagnostic evaluation of a patient with myasthenia gravis. So how we will diagnose the patient? So now let's talk about the investigations option. So in the investigation, the first is the history and physical examination is very important. The first is history and physical examination is very important. Now, upon the physical examination, we will be see the ptosis. There will be ptosis. There will be diplopia, and there might be nystagmus. And as you know that ptosis are the drooping of eyelids, diplopia means double vision, nystagmus are the involuntary movement of eyeball, which is also called as the dancing movement of the eye. So on physical examination, you will see the ptosis, the diplopia, and the nystagmus. Also, for the nystagmus, we have another very important investigation that is called as electronystagmography. Electronystagmography. In electronystagmography, we see the electrical activity in the eye. So that is for specifically for nystagmus. Also, we will do the electromyography. Electromyography, and that is for the electrical activity of the muscles. Electromyography is done for electrical activity of the muscles. And electromyography, it is actually also done for the muscle dystrophies. Also, it is done for the peripheral neuropathies. Now, this is important. So history and physical examination is important. The electromyography is important. Also, we can do the X-ray, CT, and MRI, and positron emission tomography. So the X-ray here, this is 1D, and CT will be in 2D, and MRI will be in a 3 dimension. Now, if we talk about for the thymoma, as we discussed earlier, that thymoma can lead to the condition of myasthenia gravis. So the CT scan of thymus gland is usually preferred for the thymoma. So it is very important point. Please keep in mind that for the thymoma, the preferred is another option that is the most definitive diagnostic test for myasthenia gravis, which is very important, that is Tensilon test. So please don't forget this investigation option, as it is very important and it is the most diagnostic test for myasthenia gravis, that is Tensilon test. And Tensilon test, it is also called as Adrephonium test. It is also called as Adrephonium test, and actually this test will show either decreased level of acetylcholine or it will show the impaired level of acetylcholine. So the most diagnostic test is Tensilon test, which is also termed as Adrephonium test, and it is actually it will show either decreased level of acetylcholine or it will show the impaired level of acetylcholine. Here actually the Tensilon is injected, and the Tensilon test, there is injection of Tensilon which is present in a dose of 2 to 10 mg. So initially 2 mg is administered. If there is no changes, so then administer 8 mg. Now, if we inject the Tensilon and after that if the muscle show improvement, so that means that the Tensilon test is positive and the patient has a myasthenia gravis. So it is very important that if we inject the Tensilon and if there is improvement in the voluntary skeletal muscles, if there is improvement in voluntary skeletal muscle after the injection of Tensilon, it will indicate us that that this is the positive Tensilon test, and usually the patient has a myasthenia gravis. So I repeat, it is very important that when we inject the Tensilon, after that if the muscle show improvement, it means that the patient has a disease of myasthenia gravis. If the patient show no improvement in the muscles, so it means the patient has a negative Tensilon test and there is no myasthenia gravis. Now, if there is what happens if there is Tensilon toxicity occur? When there is Tensilon toxicity occur, so there will be bradycardia occur. And how we will treat the Tensilon toxicity? We will be treating the Tensilon toxicity with the atropine sulfate. The Tensilon toxicity is treated with atropine sulfate, that is 0.6 mg IV. Also, the injection of Tensilon, that is from the dose of 2 to 10 mg, it is also an IV form. Intravenously, we will be injecting the Tensilon from the dose of 2 to 10 mg. If muscle show improvement, it will indicate us that the patient has a myasthenia gravis. Also, we will be doing the I-SPEC test. The I-SPEC test done for Ptosis. So I repeat, what are the investigation options? First, the history and physical examination is important. The electromyographic scan can be doing in such a condition. Also, we can go for X-ray, CT, MRI, and positron emission tomography. But the most definitive and diagnostic test is Tensilon test or Adrephonium test. Also, for the Ptosis, we have a I-SPEC test. So these are the investigation options. Now, let's discuss the treatment option. That how we will be treating a patient of myasthenia gravis. So the first is the anticholinesterase medication is important. So let's talk about the treatment. The first is there is anticholinesterase medication. Anticholinesterase medication. And what is the major action of these medication? It will increase the level of acetylcholine. It will increase the level of acetylcholine. And the an anticholinesterase medication. What are the medications are available? The first is there is neostigmine bromide. There is neostigmine bromide and hydrofonium chloride. So, and the neostigmine bromide, the prostigmine is the drug of choice. So here the prostigmine, it is the drug of choice. So it is important that the anticholinesterase medication, we have two options, neostigmine bromide and the neostigmine bromide. The prostigmine is the drug of choice. And secondly, there is hydrofonium chloride and the category of anticholinesterase medication. Also, we can go for the plasmapheresis. And actually in plasmapheresis we remove the antibodies that is banded with the acetylcholine receptors, and at least 3 to 4 exchange are needful. 3 to 4 exchange is needful. Also, if the condition is severe, so we can give the corticosteroids. The corticosteroids is given only if the condition is severe. Also, there is intravenous immunoglobulins therapy for boosting the immunity. And if thymoma is suspected, so for that case we can go for surgery. So thymectomy is done if thymoma is suspected. So I repeat, the treatment option is, the first is anticholinesterase medication in the form of neostigmine bromide, and the neostigmine bromide, the prostigmine is the drug of choice. It is very important. Secondly, the hydrofonium chloride is very important. So also we can do the plasmapheresis. We can do plasmapheresis, and plasmapheresis we remove the antibodies that is binded with the acetylcholine receptors, so that acetylcholine bind to the acetylcholine receptors for adequate muscle contraction, and at least 3 to 4 exchanges is needful. Also, if the condition is severe, we can give the corticosteroids, and intravenous immunoglobulin therapy is given for in order to boosting the immunity. And if the thymoma is suspected, in that condition we can go for thymectomy. So students, that's all about myasthenia gravis, and thank you so much.